Hey, so can you tell me your name?
Melissa Frankham.
Okay, and tell me where you work and what your title is.
So I currently work at Ammon Health in Anderson, South Carolina. Um, I am a clinical research coordinator. We work with Doctors McLaurin and Dr. Lomboy and some other pulmonologists and endocrinologists in the building. We screen, enroll, and follow patients in clinical trials sponsored by major drug companies and device manufacturers throughout the nation. Medtronic and Boehringer Ingelheim, Novartis are some of the big names that we work with. Been doing this particular job for about 2 years.
Can you tell me where you started as a nurse and your educational history?
So I started right out of high school, started at Tri-County Tech um, as a baby. Went to an associate degree through the associate degree nursing program, came out of that program and went directly to work on a med-surg floor. Um, Worked on that same floor for 19 years.
That amazes me.
For 19 years, we did do a lot of growing in that time. We went from being a strictly med-surg floor to an adult surgical floor. We made that transition. I became a weekend charge nurse on the floor. Then decided that I would like to further my education.
Where did you go to do that?
Um, Decided that to open up more doors and opportunities for myself. I did my BSN online through WGU, which is Western Governors University. Because I do have a large family, it took me a little bit longer than most people, but
Same here.
took about 2 years to complete that degree. And then decided that I might as well get my master's. So, because I did enjoy doing some clinical adjunct instructing for Tri-County Tech,
Which is where I met you.
my alma mater,
Right.
decided that I would do my master's in nursing education.
Where did you go to get your master's?
So the master's in nursing education came from Kaplan Online, which is now Purdue.
And that took how long?
That took a little bit longer because I did fall and break my foot in the middle of that.
Oh, I didn't know that. Okay.
So that took about 2.5 years.
Okay. So why did you decide to pursue becoming a nurse?
Becoming a nurse.
What made you want to do it?
In the very beginning, I always had the ambition of being a physician when I was a child, but then, decided that I did not want to spend that kind of time in school.
Or money.
And money. And from that became the idea of becoming a nurse.
Okay. And how does your commitment to patients and the profession affect your nursing practice?
So I always feel like I have a strong connection with my patients, because the patient is the center of your day as a nurse. You meet so many people. You meet their families. You become connected to them. Some you spend time with because you enjoy talking to them. If you sit down and talk to your patients, you find connections with them, and that's one reason I love being a nurse, because I do feel like I'm a social person, and sitting down and talking to them, I feel like I grow those connections.
So a few minutes ago we were actually talking about that it would take me about 3 years to feel comfortable. Can you tell me a story? Let's see. Can you share a story about how professional self-confidence affected your competence in a clinical practice situation?
Just being comfortable in your own skin as a nurse helps you daily in your practice, because you can recognize problems with a patient. You can bring those problems to a physician and feel comfortable bringing an issue to them and having them respect your opinion. If you're confident in yourself, they're confident in your decision, and your patients are comfortable with you as well. Like, if you go to the bedside and your patient is having a problem and you're nervous about it, or you show them that you're not confident in yourself or your
Right.
skills, they don't feel confident, and they get nervous.
Right.
So the more comfortable you are, the more comfortable they are.
Very true.
And if they sense that apprehension coming from the nurse, then they get apprehensive.
Yeah.
I'm, just
absolutely.
exuding confidence, whether you're really confident or not.
Fake it till you make it. That's how I
Whether
feel
you're
most
confident
days.
or not, you need to portray that at the
Right.
bedside.
Very true. You don't want to feel like your nurse doesn't know what they're talking about.
Exactly.
Even if they don't, you don't want to know they don't. So,
Exactly.
Gotcha.
And being a nurse is about knowing not only knowing the answer. You don't always have to know the answer. We don't always know the answer, but we know where to find it or who
Right.
to ask for it.
That's true. That's good advice. You just also talked about, when I went in your office, that y'all are moving and it's chaotic. And how do you manage the constant change and chaos in your clinical practice setting?
So, being a research coordinator, we're constantly in the midst of trials that are in startup, trials that are starting to enroll, trials that are currently enrolling, trials that are in follow-up, and trials that are closing. So, we do have to keep track of our patients, where they're at in our research studies, keeping up with them. We have spreadsheets to keep up with when their visits are due, and being sure that we keep on time with those, because if you don't, it's a what they call a protocol deviation, which can affect their data.
Right.
They want clean data, and that's our goal, is to get clean, accurate data for these clinical trials, because that's the future of medicine.
Right.
Yeah. We want to be sure that that's accurate, because when those devices or those medications go to market, we want to be sure our data backs it up.
Right.
And the FDA could come in our office anytime, any day, and inspect our work. And if it's not accurate,
Right.
it can be a criminal offense.
Really?
So, we are held to a higher standard in
Right.
clinical research.
Right.
We deal with it, but we just are slow and methodical about collecting our data, about making sure it's accurate, making sure that our sources are in fact true. And if you have a question, you ask the right person. So you ask your coworkers, you ask the sponsor, and you make sure you have a paper trail. So any conversations I have with the sponsors for questions, I always keep it. I put it in a file, put it back, because I may need that.
Do you feel like you're even in the job role you're in now? Is it even? Because I know we're supposed to document everything. Do you even find that even more important now?
Yes, it's very important. Anyway, we do document in our computer system, as well as in the paper chart that we keep on each patient. Of course, when we refer to our patients, we don't refer to them by name. They have a subject number. So we're sure to put all their subject numbers on all their documents and everything. We take off any personal information that we send to the sponsors. What we call redact. We'll take all of that off, and then we'll put their subject number on there. So you just have to be very meticulous in your documentation, and whatever you send out has to be compliant with HIPAA.
Right. Yeah. And then you had somebody coming in and auditing you, correct?
Yes. Also? Yes. So you have trial monitors. They come in, and it's like.
Are they doctors or nurses, or what are
they're
they?
Typically nurses. They have been nurses, and now they're in. They've done clinical trials. They've done the job I've done now, and they've moved up the ladder, and they go from facility to facility monitoring the trials. So they'll take all the charts and make sure your data's clean and accurate. Make sure that what you put in their data collection system is in fact what is in the chart. It all matches. So they're actually our protection for the FDA. So if the FDA were to come in and they didn't do their job, they would be liable as well as us.
It's just one more layer.
So it is a layer of protection for the sponsor and for us. They're just checking our work, basically. It's almost like having a test, being scored for a test.
That's a lot of detail, a lot of paperwork.
It's very detailed,
goodness,
but I do love it.
Yeah, I'm sure it's a total change from being bedside.
It's very different. It is very different, but I so am enjoying my studies right now, because I have gotten to know my patients on a personal level.
So you're still doing bedside a little bit.
I am. So, like, I have one study right now that's a heart failure study. It's a medication that's used for something else that they're trying in heart failure, for patients with heart failure, with a reduced ejection fraction. And I only have like 6 patients in the study, but I know them personally.
Right.
I call them on the phone, I check on them and see how they're doing. They come and see me, I draw their blood. You know, I give them their medication for the study. And then these are randomized controlled trials. So sometimes some studies are placebo versus.
Do you know who's got?
I don't know. So I have my own theories about who's getting placebo and who's getting drug.
Right.
But at the end of the day, I don't know for sure.
Right.
You know, and I've seen improvements in my patients. So it's great to follow your patients and get to know them and their families, and they come in and they're sick and they need their, you know, end of their heart failure journey, and they're looking for anything that might help them.
Right.
And I'm offering them an opportunity to try something.
Like one more last hope type thing.
Yeah. And I really enjoy that study, and I really enjoy my patients.
That's interesting. When have you made an independent clinical decision that profoundly impacted the life of a patient?
So that's kind of like what I'm talking about now.
Yeah, I was going to say it is.
In that study, what we've done is the primary investigator refers patients to us and says, here I have this patient, needs to be screened for the study. So I take their information, I take what we call inclusion exclusion for the study, and if they meet criteria, I can make a decision to call them on the phone and say, hey, I have this study. Dr. So-and-so has thought it would be a great match for you. Would you like to come in and sit down and let's have a conversation about the study? So when they make an appointment with me, they come in and we sit down and we go through the entire consent process and the protocol. This is what we're going to do. This is, you know, this is what's involved with the study. You may be taking placebo. You may be taking drug. You know, that's a chance you take. It's like flipping a coin. And then from that, they sign informed consent. If they do want to participate, and then that choice is theirs. Do they want to participate? Do they not? And you have some that just don't want to do it.
Right.
And that's fine. You know, everybody has their comfort level with that. And then you have those that are willing to do it. But and honestly, most of the patients do it not for themselves, but for other people in the future. Especially my older patients. They say, well, it may not help me, but it may help somebody else down the road. A great number of my patients have told me that they're not doing it for themselves. And it's a selfless decision for them. That they want to help someone else in the future. But you know, and they may sit down and we have a conversation and they decide that that's not for them, and I support their decision either way.
Right.
So, you know, those are the kind of decisions that are left to me, whether they enroll in the trial or they don't.
So you know that I'm trying to get my BSN. So what advice would you give me or any nurse that is pursuing higher education?
So,
especially in lieu of some of the stuff we talked about personally.
When you think about a nurse coming out of school with their 2-year degree at the bedside, they have great skills, and they're learning on the job. You know, it's fly by the seat of your pants, learning as you go kind of thing. Those are all building your skills. But when you go back to school, and some people don't see the value in it, but there is value because you learn things. You learn evidence-based practice. You learn why we do the things that we do. Why do we do them that way? Somebody didn't just decide one day that was the way it ought to be done. Somebody somewhere did a research study and proved
that's what you're doing.
and proved that that's the right way, and there's evidence to support the things that we do. And you learn those critical thinking skills. Critical thinking skills, you aren't born with them. They don't come from nursing school. They come from being at the bedside and taking care of those patients and making those decisions on the fly. But the education and the evidence-based learning teaches you how to make those decisions in
Right.
in a rapid manner, and just doing the best thing for your patient every day.
Right. Do you recommend someone getting their master's?
For some people, I do. Some people have that love of higher education, higher learning, higher professional nursing practice. Do I think everybody should? No, I don't. There is a place for people at the bedside, because without those bedside nurses, somebody's got to take care of the patients.
Right.
Do I think there are some people that should? Yes, there are people that have that ability to make those decisions and to be in professional practice. Is it for everybody? No, it's not for everybody. But you have that. You narrow down the field to those select nurses who
Right.
should go further. And that becomes evident, I think, after some years at the bedside. There's no replacement for bedside nursing.
Right. Well, thank you, Melissa.
You're welcome.
I appreciate it.
You're welcome.
I'm gonna cut this